A sharp, burning sensation ignites behind the breastbone. It is a highly recognizable discomfort that affects nearly 1 in 3 adults. Occasional heartburn is an expected reaction to a heavy meal, but when that burning becomes a chronic, progressive condition, it is classified as gastroesophageal reflux disease. The root of this condition is a mechanical failure. The body relies on a one-way valve, the lower esophageal sphincter, to seal off the stomach. If this sphincter weakens, the seal is broken. Highly corrosive acid washes backward, surging into the unprotected throat. GERD is a persistent plumbing failure. A compromised valve actively exposes delicate esophageal tissue to harsh digestive chemicals. The presentation of this mechanical failure varies. The most easily identifiable symptoms are retrosternal heartburn and the effortless regurgitation of stomach contents into the mouth. This flowchart outlines evaluation of typical symptoms. That GERD frequently wears disguises. Aspirated droplets in the respiratory tract can trigger chronic cough or severe asthma. Further down, laryngeal manifestations appear. Acid causes chronic hoarseness, throat clearing, and globus, a lump in the throat. When these atypical signs appear without the classic chest burning, a careful medical evaluation is required to confirm that reflux is the underlying cause. Recognizing these hidden clinical signals is the mandatory first step to stopping unseen, escalating internal damage. The lower esophageal sphincter does not fail in a vacuum. Specific daily habits act as direct chemical relaxants or physical battering rams against this critical valve. This table displays common chemical triggers: acidic citrus, caffeine, capsaicin in peppers, high-fat foods, and chocolate all force the valve to prematurely relax. Alongside the chemistry is the physics of the stomach. Consuming excessively large meals and carrying high body weight drastically increase intra-abdominal pressure, squeezing the stomach from the outside. Lying down shortly after eating removes the final physical barrier. Without gravity holding the meal down, the gastric contents press directly against the weakened valve. Severe GERD occurs when these chemical relaxants and physical stressors compound, eventually overwhelming the sphincter completely. The stomach lining is biologically engineered to withstand hydrochloric acid. The walls of the esophagus have absolutely no such defense. As shown in this endoscopic evaluation, unprotected tissue subjected to gastric acid develops erosive esophagitis. The result is severe inflammation, tissue breakdown, and internal bleeding. To survive this constant acid bath, the body mounts a desperate cellular adaptation. The esophageal tissue mutates to resemble the acid-resistant lining of the intestines. This structural change is known as Barrett's esophagus. It is a precancerous condition that significantly elevates the patient's risk of developing esophageal adenocarcinoma. Treating GERD is necessary to halt a progressive disease that permanently alters human anatomy. The clinical pathway to heal this damage does not begin with prescriptions. It begins with evidence-based lifestyle modifications. Dietary interventions, such as the portion-controlled Mediterranean meal seen here, actively eliminate the chemical triggers and reduce systemic inflammation. Structural interventions address the physical stress. Intentional weight loss relieves internal pressure, while establishing a strict 3-hour fasting window before sleep ensures the stomach is empty. Patients can also utilize a mechanical gravity hack. Physically elevating the head of the bed keeps any residual acid trapped in the stomach downward overnight. These foundational habits correct the physics of reflux. However, long-standing mucosal damage often requires a heavier, escalated conical response. When lifestyle modifications fall short, physicians rely on this medical algorithm to escalate care. Initial pharmacologic steps utilize over-the-counter antacids for immediate neutralization, followed by H2 blockers to slow acid production. For long-term healing, the standard of care moves to proton pump inhibitors. These medications reliably create the sustained low-acid environment required for erosive tissue to heal. They are carefully titrated to the lowest effective dose. This standard sequence is overridden entirely if a patient presents with specific alarm symptoms, noted here in the upper right: extreme difficulty swallowing, unexplainable weight loss, or gastrointestinal bleeding. The presence of any of these alarm symptoms demands immediate endoscopic evaluation by a gastroenterologist to rule out cancer. Gastroesophageal reflux disease is a mechanical failure with severe chemical consequences. By identifying the triggers and following the evidence-based medical pathway, patients can heal the internal damage and reclaim their quality of life.